Okay.
Airport is in Bangalore. Airport.
Right.
We have to see the idol through a small window, sir. Udupi Krishna.
Good evening, sir. Sorry to disturb.
Please,
8
sir,
o'clock.
please, sir.
So I think Dr. Professor Ebos Momin is held up in the surgery, I guess. So he'll be joining a little late.
Shilpa
Gopi sir
madam, I
is
saw.
just finishing a meeting from Calicut. So we will have Dr. Rawat is here. And I'm sure Sri Kumar sir also will be able to join. So
Shilpa
friends,
madam has joined, sir.
yes, sir. Okay, okay.
Shilpa madam has joined.
Madam, good evening, madam.
Good evening, madam.
So today's case is kindly
Good evening,
contributed by.
everyone.
Good evening, madam.
Good
Professor
evening.
Shilpa madam from KEM, and we have the other case kindly contributed by Professor Saravanan sir from Madurai Medical College. I thank all the faculty for joining us and our own senior faculty with us, Kanna sir, Shanai sir, Srinivasan sir, Karnakaran sir. Hitesh Anderia sir is gone for trekking at Himalaya, so I think he has excused himself. So we will start the first case. Dr. Rahul, are you ready, ma?
Yes, sir.
Yeah, please share your PowerPoint and start your presentation. Good luck to both of you.
Thank you, sir.
Thank you.
So I am presenting a case of peripheral
Dr.
vascular
Rahul,
disease.
you have to switch on your video,
my-
Dr. Rahul. We are unable to see you.
Yes, sir. It is started, sir. Yes, sir.
We are unable to see you, ma. We are able to see your PPT. Yes.
Yes, sir. Okay, sir. So starting, sir. So I am presenting a case of peripheral vascular disease. My guide,
Ma, we are unable to see you or your PowerPoint.
not both.
Rahul, we could see your PPT. So just keep the PPT on. It's okay if we don't see you.
Okay, ma'am. So it is started.
No, ma'am. Will you please share your PPT? Please unshare this window. As madam says, maybe share PPT, if you can show it well, that should also be fine.
Okay. It is on a screen, sir.
No, Rahul,
ma'am.
go back to your Zoom thing and share screen again.
Okay, okay. It started. Now, okay.
No, your
But now
PPT
we
is
can
not
see
showing.
you. We can see you, but we can't see the PPT. Yeah.
Mute, madam.
Okay.
Okay,
Wait.
now.
Okay, good luck to you.
Now it's okay.
Okay. So I'm presenting a case of peripheral vascular disease. My guide, Dr. Shilpa Rao, ma'am, head of the unit, KM Hospital, Mumbai. I am a third year PG resident at the KM Hospital, Mumbai. A 40-year gentleman resident of Dadar, laborer by occupation, presented with a chief complaint of pain in a right lower limb in 6 months, pain in a left lower limb since 4 months, and rest pain in a right lower limb since 2 months. Patient was apparently all right 6 months back when he first started experiencing pain in the right leg and foot, which used to occur at a regular interval, especially after walking for 1 kilometer. History of cramp-like pain in the left leg since 4 months. Slowly over 4 months, pain has started increasing in a frequency, and at a present, even after walking 500 meters. Pain is intermittent, cramp-like, and severe enough to compel the patient to take a rest. Pain disappear completely on a resting 3 to 5 minutes. Since last 2 months, he has continuous pain in the right foot, which is severe, interfere with the sleep, not relieved by analgesic and partly relieved by hanging the leg down by the side of the bed. There is no history of any trauma, no history of swelling, dilated vein, no history of chest pain, postprandial abdominal pain, no history of blurring of vision, headache, no history of impotence, no history of discoloration of finger on exposure to cold, no history of any long drug ingestion of any medication. Past past history, no history of any comorbidity, ischemic heart disease, or cerebrovascular attack, no history of any previous surgery. Personal history is on a mixed diet, history of tobacco chewing since 12 to 15 years, history of alcohol intake since 12 to 15 years, no history of any bowel and bladder complaint, no history of similar complaint in a family. Summary, a 40-year gentleman with a history of tobacco chewing with no comorbidity, with a complaint of wrist pain in a right leg for 2 months and intermittent claudication in the left lower limb for 4 months. Yes, sir.
You can go to the first slide, huh?
Yes, sir. Yes, sir.
Pain in the right lower limb, pain in the left lower limb. Next slide.
Rahul, what do you understand by the rest pain?
Sir, rest pain, it is an pain occur at during rest. It is a continuous excruciating pain, which is occurred at a rest.
So this patient had pain in the right lower limb for 6 months. What type of the pain can you describe? Okay, go to the next slide.
It is an intermittent cramp-like pain in a calf and a foot.
So is that the claudication or not?
It is a claudication, sir.
What do you basic meaning of the claudication?
Claudication, it is a type of pain. It is a cramp-like pain which is occur in a foot after any physical activity, and it is relieved on a rest for 3 to 5 minutes.
But what is claudication? What is the claudicus?
Claudicus, it is an cramp-like pain, sir.
Limpy, you know?
Yes, a limpy.
Yeah, it's
Limpy.
the limpy which is there.
Yes,
So
a
the
limpy.
patient has to limp because of that pain which is there.
Yes.
What is the claudication distance?
Claudication distance, it is an distance at which a patient have a history of pain on walking.
So
Usually-
starting, okay, starting of the pain. You know, the pain will be there for a very long time to this patient. So you have to tell the claudication distance when he starts getting the pain. You know.
Yes, sir.
Now, can you tell what are the various phases of claudication?
Phases of claudication, sir. First, it is classified by White classification, grade 1. It is an pain occur at walking, and after continuous walking, the pain get relieved. After that, in a grade 2, a patient walk with the pain, and grade 3, patient have compelled to take a rest for pain, and grade 4, rest pain.
Is the rest pain a part of the claudication, or it's a
No,
different?
It is a different thing.
So claudication is only 3, grade 3
Yes,
up.
sir. Yes, sir.
So rest pain is not claudication.
Yes, sir.
Now, why did you ask about the impotence in this patient?
So, to rule out Leydig syndrome, which is occurred due to occlusion in a aortoiliac region.
So aortoiliac is then on the one side or both sides?
It occur in both sides.
The patient with a bilateral pain,
Yes,
along
sir.
impotence will be there.
Yes.
Now you are told about the tobaccos here, but you are not told that how much is, because this is very important in this patient. That how much is tobacco smoking, how many BDs per day, or how many cigarettes per day, or which type of
Type of tobacco.
He is a history of tobacco chewing, not a smoking.
the tobacco chewer. Can you go to the tobacco one?
Yes, sir.
Yeah, go to that slide. History of tobacco chewing is there. Okay. In
Yes,
what
sir.
form he was chewing that?
Sir, he is mixed tobacco with the chuna, that is a calcium white color material, and put it in a mouth.
And did he used to keep it overnight or not? Many times, once a patient takes the quid,
Yes, sir. Quid.
keep it in the sulcus overnight.
Yes, sir.
Because that is a classical history, especially if the patient is having some type of the oral cancer is there, then that classical history is there.
Yes, sir.
And how do you define the alcohol? Alcohol intake since 12. How do you say how much he is taking?
Sir, he is taking around 180 ml per day.
180 ml per day for last 12 to 15 years.
Yes, sir.
And he does not have any other problem, because of the alcoholism, apart from
No,
the
sir.
leg pain.
History of occasional drinking, sir. That is.
Occasional drinking. No? You are saying
Okay.
180 ml per day, that is
No.
too much.
Yes, sir.
Okay.
Dr. Rahul,
Yes, sir.
can I ask you a few questions? One of them is about the intermittent claudication. Please use one at the end. Is a severe intermittent crampy pain felt in the muscles involved, and it is reproducible. What do you mean by that? Very important one word you should use. Reproducible means what?
Reproducible, that is, he is having similar complaint again and again over a period of time while walking.
Yes. So, because what are the other causes of pain in the leg while walking?
While walking, might be he is having some neurogenic claudication, osteoarthritis.
Yes.
Yes, sir.
Yes.
Or might be stenosis spinal.
No. That's okay. What you are telling, neurogenic. It comes under lumbar canal stenosis, etc. How do you differentiate from that?
Sir, I will differentiate it. Neurogenic claudication, he is having history of pain on a walking.
No.
And not relieve.
History of pain with the first step itself.
First step, yes, sir. Early.
Any problem with the disc prolapse, or you said no, lumbar canal stenosis, or metastasis in the vertebrae, TB spine, any movement which involves the starting itself, bending, stooping, coughing, that causes pain. Okay.
Yes, sir.
How to differentiate this from the gluteal claudication?
Yes, sir.
How to differentiate?
Sir, vascular claudication can be differentiated because neurogenic claudication can not relieve as early as a vascular claudication.
Okay. Right. Now, one more question from my side. How will the pain in a venous disorders of the leg?
Yes, sir.
Veins. Next case is a varicose veins, but doesn't matter. How to differentiate arterial problems from venous claudication?
Venous claudication having history of swelling also.
Is it a severe pain, or what kind of a pain is that? When the varicose veins suffer from incompetence is there, what do they complain?
So, venous pain,
heaviness and a dragging.
Heaviness, edema and swelling and heaviness.
More in the late in the evening, more on standing.
Yes, sir.
Relieved on?
Relieve on a leg elevation.
Leg elevation. So this is the first thing you should try to differentiate between the arterial causes, venous causes, neurological causes, and very importantly, other causes of the leg, like knee joint, osteoarthritis, etc. Last question from my side at this stage of history. When he said pain is in the calf region and foot region, where do you think the probable obstruction?
So femoropopliteal region.
You should always say one artery above. Most probably femoropopliteal. Okay.
Yes, sir.
What is the common site of that area where it gets occluded in atherosclerotic disease?
Atherosclerotic disease.
In atherosclerotic disease, I mentioned to you about femoropopliteal region, which is that specific area where the Anywhere it can get narrowed, but what is the one of the areas where it is in the Hunter's canal? What
It
is
is a
Hunter's
junction of three vessel.
Sorry?
Junction of three vessel.
No, what I meant to say is one area is the Hunter's Canal. Where is this Hunter's Canal?
Hunter's Canal. It is behind the sartorius, lower 1/3.
I think you confused it, but I suppose it's a hiatus in the adductor magnus. Okay. Where the superficial femoral artery passing through it, then becomes a femoral artery. Okay. Other area is femoral artery bifurcation, right?
Okay.
There is a profunda there, no? Profunda. Okay. So there's a profundal narrowing also can take place. That's why you do the profundoplasty, etc. Okay. So
Yes, sir.
where do the patients with a common iliac thrombus or occlusion will complain of pain?
Pain in a buttock and thigh region.
Thigh region, thigh. So that's what. So aortoiliac is a bilateral and varicose. Okay, sir. Thank you from my side. Yes.
What is the triad you get in that Leriche syndrome, Rahul? One is you have said gluteal claudication. Number two,
there's a pain in a buttock and thigh region. There's a gangrene in a leg, and there's a history of impotence.
Leriche syndrome triad is one is gluteal claudication. Number two is absence of femoral pulse, and number three is impotence.
Femoral pulse.
And that's the triad of Leriche syndrome.
Yes, sir.
You said tobacco chewing. How does tobacco chewing affect the arterial system, as you said?
So tobacco contain nicotine.
It has got another thing called, there's one thing called TGP, tobacco glycoprotein is there, which sensitizes the nerve endings. So what happens is there is a chance of vasoconstriction more. This tobacco glycoprotein again, what happens is it increases the viscosity of the blood. So that is why we always say whenever a TAO comes, the first treatment is stop tobacco. So you should mention what type of tobacco. Is it chewing? You said chewing, yes. No smoking.
No smoking, sir.
Yeah, right. Right. And you said pain in the right and it has gone to the respite. So the right pain, the disease is progressing.
Yes, sir.
6 months. The left leg is static. It is not progressing.
Okay.
So no comorbidity, you said. What are the comorbid condition you asked for?
So diabetes mellitus, hypertension, hyperlipidemia, and there's any history of ischemic heart disease, or there's any history of stroke.
Yes. Why do you ask for all these things?
To rule out the etiology of occlusion, because in diabetes itself is a risk factor.
Yeah, in other diseases, any thrombus or any ischemic heart diseases,
yes, sir.
Any thrombus can come down, get lodged. Okay.
Yes, sir.
No family history. Yes. Okay. Good. Sir, can we go proceed further? Yes, you go to the general examination.
Yes. So general examination, I have examined the patient in a proper light and exposure with informed consent. Patient is fully conscious, cooperative and oriented, average build and fairly nice, height 170 centimeter and weight 65 kg, BMI 22.5. There's no history of any palliative sinuses, clubbing or lymphadenopathy. Patient is febrile, pulse is 68 per minute in a right radial artery with a normal force volume character, no radial or radio. There's a radiofemoral not palpable on a right and right side with a normal amplitude. BP 110 by 70 mmHg in a right brachial artery. Saturation 98% on a room in a right index finger. On a local examination.
In the case of, 1 minute, in the case of a peripheral vascular sclerosis, the ideal thing is you should take blood pressure in all the 4 limbs.
Yes, sir.
You have both lower limbs also, isn't it?
Yes, sir.
So you should take, the ideal thing is you should take BP in all the 4 limbs.
Yes, sir.
Okay.
Yes, sir. On inspection, so bilateral lower limb skin is thin and shiny with a loss of subcutaneous fat and hair.
Inspection of what? That should be your idea thing. Inspection in broad is not Rahul. Inspection of both the lower limbs.
Lower limb, both.
Yeah, that is should they had always had. Whenever you put inspection, any of the cases, inspection of the abdomen, inspection of the oral cavity, like that, the inspection or local examination of the lower limbs.
Yes, sir. So on inspection of the bilateral lower limb, skin is thin and shiny with a loss of subcutaneous fat and hair. No tail are brittle. Guttering of vein on an elevation of limb. No gangrenous changes. Cross-leg test. No oscillatory movement on either limb. Joint movement restricted and painful at a right hip and knee joint and ankle joint. And no evidence of locomotor brachialis. On palpation, temperature. Right lower limb temperature is lower than the left lower limb up to mid-thigh region. Hyperesthesia is present over the right thigh region. No tenderness or pitting edema or adjacent skin. No history of tenderness along the line of superficial vein. No inguinal lymphadenopathy. So I have done all artery palpation. So dorsalis pedis, posterior tibial artery, anterior tibial artery, and popliteal artery are absent in both lower limb. And femoral artery is present on the left side. Radial, ulnar, brachial, common carotid, and superficial temporal artery palpation present. Auscultation, no bruit is heard along the course of artery in a leg and abdominal aorta and cavity. Systemic examination, abdominal examination, soft, non-tender. Respiratory examination, bilateral air entry normal. Cardiovascular system S1, S2 present, no murmur, and patient is conscious and oriented. So case summary, a 40-year gentleman with a history of chronic tobacco fever with no comorbidity presented with the complaint of right lower limb pain since 6 months and rest pain since 2 months. On examination, changes of chronic ischemic present, right side pulsation distal to femoral absent, left-sided pulsation distal to popliteal absent. So provisional diagnosis, peripheral arterial occlusive disease affecting bilateral lower limb, right more than left with a critical limb pain of right foot and leg probably due to atherosclerotic etiology, causing occlusion at a femoral popliteal in a right lower limb and popliteal occlusion in the left lower limb.
Rahul,
Yes,
whenever you prepare the slides for this online, some spelling check you have to do, number one. Okay.
yes, sir.
Last time also we have told, not only this popliteal, there are many other mistakes. Doesn't matter. Please go and check again. Okay, number one. Number
Yes,
two, all the slides, you better put the date and time. Okay. At least date and number. I'm sorry, number. Okay. Very easy to put the numbers for the slide. Okay.
Okay, sir.
Go to the general physical examination slide. Yeah, general physical examination. Why you look for pallor? Simple questions, but important.
So, pallor might be occur in a Raynaud disease to rule out.
No. Are you suspecting Raynaud's disease in your patient?
No, sir, not it.
Does Raynaud's affect the usually lower limb?
No, sir, upper limb usually.
Which part of the upper limb, which finger is usually not affected in Raynaud's? Any idea?
Thumb, sir.
So it's usually we are talking about now lower limb atherosclerotic disease. So pallor importance is, after all perfusion of the tissues, you need hemoglobin, correct?
Yes, sir.
So you need a good blood, no? Suppose it's 6 grams, 7 grams, perfusion is obviously inadequate. So that's another thing you should know. Okay, that's the reason. Okay, other things are not all that important here, lymphadenopathy, etc. You have written their height, weight, and other things. The next slide, just one comments on the next slide. See, you have mentioned about radial artery, and you have even mentioned here only thickening is present or not. I don't know whether you have mentioned earlier anywhere. So if there is a thickening of the arteries, radial, ulnar, brachial, or whatever it is. Okay.
Okay, sir.
Not only volume here, that's important. In addition, that thickening, that's one of the signs. So what I wanted is, what are the evidence of atherosclerosis in your patient?
Yes, sir.
Other than the thickening of the vessels.
Yes, sir.
What are the in general physical examination? Do you find any other evidence? General physical exam. Suppose you examine, no evidence. Suppose patient is 70, 75. Anything else you will get? Ice anything fine, Arcus analysis, you heard of that term? Hello? Hello? Rahul? Am I audible, Srinivasan?
Yes, sir, you're audible, sir.
Rahul?
Rahul, I have heard about Arcus analysis, old age.
I think he's disconnected or what?
Dr. Rahul?
Signal might be lost.
Okay.
No, he is inside. Probably is, as you say, signal may be weak, I think. Sir.
Yeah.
I think he's trying to rejoin. Professor Karan Rawat could not join last week, sir, because of internet issues. Thank you, sir, for joining this week.
I'm so
in
sorry.
The hospital only, sir, college.
Yeah. I just finished my rounds. I'm the hospital.
Okay.
Sir, please ask questions, sir. Please, sir.
Definitely. I'm just listening to the knowledge you are imparting.
You are welcome to ask, Dr. Karan.
Sir, do you ask the PVOD cases to take BP in all 4 limbs, sir?
Yes. Yeah, but the thing is, our standard BP cuff is not meant for the lower limb, sir.
Lower limb, sir.
The girth is more. So that is why, ideally, yes, there is a separate BP cuff, but we don't have that. So upper limb, at least both limbs. That's why this ABPA is there. So,
sir, actually, the erstwhile cloth type of BP cuff is good, sir. They are very long. Nowadays, we don't get it, sir. That has a long length, almost 4 foot or 5 foot. It comes.
Correct.
2-3 rounds it will come, sir, in hand. Now it not even 1.5 round.
Now we won't get it. Long back I have used once. Very long back.
The Mercury BP cuff.
Mercury is now almost left, sir, because NABH, when they ask us not to dismantle all the Mercury. Last time itself, we dismantled everything, sir. Only dial type and digital type we are using now.
Yeah, even for checking temperature now, we are not supposed to use this Mercury thing, no?
The digital ones or the non-contact ones are now become the order of the.
But, sir, there is a lot of temperature changes I have found, sir, in this shoot plus regular temperature with the thermometer.
Yes, sir.
At least one, sometimes I find difference. Patient is febrile and showing normal temperature.
Very true, sir. Very true. And the pediatric people have that ear thermometer, sir. That looks fairly okay, but definitely it is not cost effective, sir. Every time they change the sensor cap. I will try to speak to Rahul, sir. 1 minute.
Till then, I will make my postgraduate join the class.
1 second, sir.
Karnataka raining heavily, sir. Chennai, sir.
Yes, sir. It's heavy. It's a heavily raining even now. Now also, they have declared red alert today, tomorrow, day after, 4 days. So, lot of people, low-lying areas are flooded here.
Flooded here, yes, sir.
And breeze is very heavy for coastal Kerala belt, Mangalore, our area up to Karwar. So
Udupi is also a low-lying area, isn't it, sir?
Not exactly, but a little away. Just another 3-4 kilometers is the Arabian Sea from Udupi.
Yes, sir.
So a lot of breeze there.
Yes, Rahul.
So I've told him to join on the phone because there is a huge network issue inside of KEM. We have strong calls. So I think since he's finished the basic exam, he could join on the phone and try and answer your questions. Is that okay?
Yes, madam.
That will be fine, ma'am. Sir, Tinvasan sir, you have the PPT, sir.
I have to load it from the.
No problem, sir. Let the discussion go, ma'am. That's fine. That's fine.
That's what, because there is a.
Yes. He has told right up to the femoral artery, it's absent.
Okay.
Left up
Go
to
ahead,
the.
doctor.
He said, do you have any pictures to show? I will upload and see. Rahul?
Yes, sir.
Do you have any CT pictures or any?
Yes, sir. I have, sir.
So Rahul, you could send the entire PPT to one of them, and maybe they could put it, or you started.
1 minute, madam.
He is fine, ma'am. I think he himself is fine.
Okay, fine. A little bit
The
of.
Srinivasan sir, slides are back, sir.
Okay, okay, sir.
I think there's network issue.
You can switch off your video.
Rahul, please do what? You are okay, Rahul. Please go ahead.
You can switch off your video.
Yes, sir.
I just want to ask you, Rahul, inspection, some of the findings, you are very fast, and you have only mentioned few things. You have written some nail and something.
Shiny skin.
Yeah,
shiny skin and lots of hair.
Yeah, you have to say any interdigital cracks, brittle nails, any metatarsal hollowing, narrowing of the space. Then calf muscle girth, you have not mentioned. I'm not sure if you have mentioned. So calf muscle atrophy or a narrow. What does this signify? All this shiny skin you mentioned, loss of hair, brittle nail. What do they signify? What do they tell you?
They signifies the chronic changes of PVD.
Okay, I'll just put it in a quick way. It indicates blood supply to faciocutaneous compartment. Okay.
Yes, sir.
Please remember, easy to remember. Whenever there is a collaterals develop in a chronic occlusion, the priority goes to the muscles. Okay. Muscles have to have some blood supply. So in the bargain, faciocutaneous compartments, that is what reflected in the form of the shiny skin and other things. Okay.
Yes, sir.
So of course you have mentioned about there's any gangrene you should mention, and again in the palpation I'm not sure. Did you mention about postural test?
Yes, sir. I have mentioned the oscillatory test and Berger test.
You have mentioned. Okay. And capillary filling also you have to mention. Okay. Yes, and you have not mentioned aorta, if I'm not wrong, palpation of the aorta. Okay.
Yes, sir. Palpation of aorta.
Where do you feel for the aorta?
I feel the aorta above umbilicus at the level of L2 vertebra.
See, in the surface anatomy in the abdomen, you can't search for L2, no? So you can't search for L2. So just above the umbilicus in the epigastrium, it almost becomes umbilical and epigastrium. Okay.
Okay, sir.
Where do you look? What is that you are looking in aorta?
Aorta, sir, the calcified aorta calcification and.
No, just hold on. Can you feel the calcification by palpation?
No, sir.
Then what is that looking means? I am still in the clinical. Use your clinical science. You look for aneurysm. Okay.
Aneurysm. Yes.
Aneurysm. Similarly, popliteal artery is another site of a peripheral aneurysm. So bruise, all that you should mention. Okay. Similarly, in the upper limb, you need to mention common carotid artery, superficial temporal. See, these are every detailed pulse palpation of the head and neck vessels, upper limb, lower limb, aorta. That has to come. Okay.
Yes, sir. Yes,
okay, sir. That's all from my side.
Rahul, how do you feel the temperature in the limb?
By the back of finger.
How will you do that?
First, we fill the normal limb. After that, we will proceed to this limb.
And will you go proximal to distal or distal to proximal?
With the back. From proximal to distal, sir.
Proximal to distal. Good. Now, in your examination of the pulse, you just said it is absent or present.
Yes, sir.
But you have to always tell that how much is the volume of that. Now, what is the normal pulse? How do you write that?
Normal pulse, I will write that 72 per minute, normal in volume, normal volume, tension, and
Now, how do you say it is a normal pulse, or this is a bounding pulse, or this is the absent pulse?
so absent pulse we didn't feel any pulse. And bounding pulse, we have very high amplitude pulse we can feel.
No, but if you have to describe that, if you have to write that, how will you write that?
72 per minute, increase in the volume.
You know, you have to, the normal pulse is 2 plus. Okay.
Okay,
The
sir.
normal
2 plus.
pulse is 2 plus. 1 plus is, it's a weak pulse. And minus is the absent pulse.
Okay, sir.
3 plus is the hyperdynamic pulse, which is there. Okay.
Okay.
So the normal pulse is 2 plus. So to write down the 2 plus sign, then you say it's a normal. So rather than saying it is absent or present, you have to mention that whether it is 1 plus or 2 plus or 3 plus.
Okay, sir.
Now in this patient, it's a patient of 40 years, and you have made a diagnosis of atherosclerosis here as the first diagnosis. Are you
Yes, sir.
justified by that?
Yes, sir.
40 years patient having the atherosclerosis?
Not usually, but
So if it is occurring at the 40 years, what type of atherosclerosis it is?
it might be Berger's disease if it is less than 50
But this is
years.
different, you know. We are not.
Yes, sir.
That's what we have to see, that whether it is a Berger's disease, you will make a diagnosis, or whether you will make a diagnosis of atherosclerosis. If you to make a diagnosis of atherosclerosis,
Yes, sir.
then it is not a classical atherosclerosis. What is the pre-senile atherosclerosis? Okay, pre-senile atherosclerosis. And in the pre-senile atherosclerosis, you will get certain common features which will be there, like the patient may be obese, patient may be there, the patient might be having the hypertension, there may be arcus analysis may be there, or there may be genthylisma may be there on the face. So all those features which will be there, then you can say it is probably pre-senile. 40 years is not the age for the atherosclerosis. 40 years is the age for the Berger's disease, okay, which is involving the bilateral limb, mainly which is confined to the near the popliteal area. So I think there is no hesitation in saying that you can keep the first diagnosis as a case of Berger's disease rather than as the case of the atherosclerosis here. Now, what are the Shenoy criteria for that, for the Berger's?
Tobacco chewing with male gender, less than 50 years of old age, distal extremity involved, and there is no history of any diabetes mellitus or hyperlipidemia, and there might be possibility of thrombophlebitis or not.
So at least out of the 6 features, 5 features are there in your patient.
So might be gangrenous changes.
So almost all the features they fit. The patient is less than 50 years, a male patient involving the bilateral lower limb. The distal pulsations have gone. So it's almost fitting into the Berger's disease. I think if you keep the first diagnosis of Berger's and the second as atherosclerosis, probably more justified by that. Okay.
Yes, sir.
So how you are going to work up for this patient?
So first, I will do a routine workup, hemoglobin, electric AFT, RV, random blood sugar level. After for diagnosis, I do
What are the things? What are the things you are going to do in the blood examination? Let us go to the first the blood examination. What are the things you want
blood
to
examination.
do?
So I will check if he's having some gangrenous changes. So I will look for any infection, rise in the WBC count, hemoglobin level.
First, the infection. Yeah,
After that, platelet level.
Yes. Then infection.
Yes, sir.
Second is the diabetes.
Second, I will diabetic or non-diabetic, random blood sugar and HbA1c level.
Then the lipid profile of the patient.
Yes, the lipid profile I will do. Yes, sir. To check for very low density level and high density lipid level.
So that is for the blood examination.
Yes, sir.
Then what you will do?
I will do a chest X-ray and abdominal X-ray.
Abdominal X-ray.
After that, I will go for.
Why
Yes,
you want to do abdominal X-ray?
To see any abdominal aortic aneurysm.
You can see in the X-ray the abdominal aortic aneurysm.
There is
Well,
any.
what are the features of aortic aneurysm on plain X-ray? Tell that. On plain X-ray of the abdomen, what are the things by which you can suspect probably the patient has got the aortic aneurysm?
Not clearly, sir.
You will see a shadow of that in that area.
Yes, sir. Shadow of that area.
With the sauce shadow may be obliterated because of the big mass which may be there. And then the most important, the calcification.
Calcification.
You can see the calcification on the plain X-ray of the abdomen. And then only you can suspect that the patient might be having the aortic aneurysm.
Yes,
so better than that, if you want to see the aortic aneurysm, what you will do?
CT scan.
Before the CT scan?
Before CT scan.
No, before the CT scan. Can you do something to know that the patient has got
aortic aneurysm? USG sonography.
Yeah, ultrasound. Ultrasound of the abdomen, the duplex scan which you will do.
Yes, sir.
And that is the probably most important thing which you are going to carry out.
Yes, sir.
That will tell you whether the patient has got this one, what is the extent of the disease is there, whether it is confined to the aorta, abdominal aorta, it is going up also, or it is going down into the iliacs. So many, and what type of the aneurysm it is. All those things can be seen on a ultrasound and a duplex scan.
Yes, sir.
What are the findings of ultrasound or duplex in the Burgess in the lower limb?
In a Burgess disease duplex scan.
Yes.
There's a low amplitude wavelength of triphasic, low amplitude triphasic wave or monophasic wave. I can see on a duplex scan.
So normal pulse is, what is the normal pulse? What is the normal pulse on duplex? How does it look like? What it is called as?
It is triphasic waveform.
Okay.
Yes, sir.
And so once the obliteration starts, then it becomes
monophasic.
No, before the monophasic,
decrease in amplitude.
Between the triphasic and the monophasic, something else is there.
That is.
It is biphasic.
Biphasic. Biphasic.
So from the triphasic, it will go to the biphasic, and then it will go to the monophasic.
Monophasic.
So what things you will see in the case of atherosclerosis, and what things you are going to see in the Burgess disease?
In atherosclerosis, I will see
definitely there will be proximal involvement will be there. That's the most important thing. That you may deal with like the iliofemoral component which is there, or the outer iliac component which is there. While in the case of the Burgess, it will be the distal component which will be there. It may be femoropopliteal or to the popliteal involvement may be there. And you get a classical what is called the corkscrew sign which is there. In the case of the Burgess disease, then you can get the calcification in the case of the atherosclerosis as compared to the Burgess disease. So these are the few things which are there by which you can differentiate on duplex scan that whether you are dealing with the case of atherosclerosis or you are dealing with the case of a Burgess disease. Anything else you want to do?
I will do if I want to plan any surgery. I will plan for CT angiography, MR angiography, DSA.
So what are the various types of angiographies you know?
Angiography, CT angiography, MR angiography, and digital subtraction angiography, DSA. And Felding.
Before all those things came, what was the way to carry out the angiography? Before we had this MR and the CT and the DSA,
yes, sir.
What type of angiography was done?
CT angiography.
No, CT, before the CT.
Before CT. Felding angiography.
You know what is the Seldinger's technique?
So it is an cannulation of any femoral vein, and to which we put a dye in a
not the femoral vein, femoral artery, no?
Femoral artery, sorry.
Yeah. So that was the conventional angiography which was done. So the conventional angiography now it is done at the time of the therapeutic intervention, not for the diagnostic one. If you are planning for any therapeutic intervention, then you will go through this technique, the Seldinger's technique, which is there. Okay. So if you are planning for any active intervention, then you will go for these. If you are not, then you will base your treatment on the basis of the ultrasound or the duplex scan. Now, do you have the pictures of the angiography in this patient?
Yes, sir. I know.
Can you project that? Is it possible?
Yes, sir. I will try.
Okay. So tell the findings. What are the findings?
So here is on the left lower limb, there is a distal superficial femoral artery occlusion, and after there is a distal runoff, and on the left lower limb there is a posterior tibial artery can be seen because of collateral development, and on the right limb there is a whole superficial femoral artery occlusion present.
What is happening in the right lower limb?
So from the origin of superficial femoral artery, there is a complete occlusion.
Can you see somewhere near the aorta something happening?
Yes, sir. There is also a narrow vein at the origin of common iliac artery.
So right at the common iliac origin, the block is there.
Yes, sir. Yes, sir.
And then you see again the iliacs, but beyond the iliacs, you are not able to see anything.
Yes, sir.
So if you keep this one, you know the task classification which is there?
Glass.
TASC. TASC.
TASC, transatlantic. Yes, sir.
Yes. So where does this patient fit? According to that.
According to he more than 50 centimeter. So class 3 or 4.
So is this patient for a endovascular management or is it for a open treatment?
Very good question, sir.
So we can.
The most important thing which is there in this angiogram, there is hardly any distal runoff is there on the right limb.
Yes, sir.
There is no distal runoff in the right limb. So probably none of any active treatment will be helping in this patient.
Yes, sir.
And either the open treatment or the endovascular treatment. But on the left side, at least you can see one artery which is there. Out of the 3 arteries, at least you can see on the left side one artery. So you can think of carrying out certain thing in the active hair. But on the right limb, probably I do not think that you can carry out any active treatment for this.
Yes, sir.
Okay.
Rahul, what about the, can you tell me some guiding principles of management of this occlusive arterial disease? Some principles.
Yes, sir. So first, I will treat the patient with a lifestyle modification.
Yes.
Yes, sir. Stopping of smoking, tobacco saving, and healthy lifestyle. Modification, healthy diet. After that, keep the lower limb warm.
Can Nikhil mute your audio, please, Nikhil?
Dr. Nikhil, kindly mute your audio.
Yeah, okay. So first is a lifestyle modification, stop smoking, reduce weight. What else you mentioned?
After that, keep lower limb warm.
How do you make your lower limb warm?
By giving a warm gloves or anything else.
I mean, that is probably what you are referring in maybe very cold places of minus 30 degree, minus 20 degree, Russia or wherever you want to probably. So it doesn't happen in Indian setting. Okay. I don't think in Mumbai you find that kind of, or neither in my place. So basically lifestyle modification, stop smoking, reduce weight, hypertension to be controlled, diabetes to be controlled, and a programmed or a monitored walking. You know, you can't say don't walk. You need to guide him for a, train him for a gait walking. Okay. Yes. Next. That's the first one.
Yes, sir. After that, I will go for medical management. And
example.
Silastazole. After that, aspirin, clopidogrel, Trentel.
So, probably aspirin and is definitely indicated. Silastazole. Yes, and you mentioned about clopidogrel. Clopidogrel, is it commonly given for this arterial disease or the lower limb unless there's a cardiac element? Of course, before I forget, she is a young patient, as Dr. Khanna sir was telling from beginning. So smoking is one factor, but in addition, whether he has got some other factors, the vessel involved is above. You have seen that common ileal, femoral, bigger vessel also involved. Whether he has got some other disease, including hyperhomocystinemia, that also to be ruled out in this patient. Doesn't matter. So you have to evaluate for a coronary angiogram also in this patient. That is another thing to be kept mentioned. Yes, what are the things what are the other principles?
I will start statin.
What is the purpose
statin
of
group of
statins? What is the purpose of starting statin? Yes, what do they do? How do they
to reduce? They increase the high density lipid. Yes, sir. Rosuvastatin.
Most importantly, yes, I agree, but it helps in preventing the dislodgement of the plaques. Plaques. So very important, atheroembolism. This is stroke, cardiac event, or limb ischemia. This is one of the important uses in addition to whatever you have mentioned. Yes. So drugs you have mentioned. Then what else?
After that, some intervention radiological intervention,
Pain
stenting.
relief. Pain relief. Never forget the pain relief and
Yes,
care of the ulcer.
pain
If
relief.
there's an ulcer, you have to treat it. Okay.
Yes, sir.
If there's an ulcer. And if there's a ganglion, most of it's a dry ganglion. Don't try to disarticulate the toe. Dry. As long as there's no infection, wait till there. So now come back to some of the interventional thing like right leg. Would you like to do some vascular graft? If at all, what is the reason? Right leg. Picture, I think I remember, right? Not much of collaterals. Yes.
Yes, sir. If there is any gangrenous changes present, so I will go for any.
There's no gangrene, no, in your patient.
Yes, sir. No gangrene at present.
So would you like to wait till the gangrene set in or any indication is there? He's got claudication, correct?
Yes, sir. So I will wait, sir. Wait.
You wait. He has got rest pain.
Sir, now rest pain have been reduced.
You mean to say he has responded to the drugs. So what is the thing you have to warn this patient? Because I know that it may be difficult, but at least there is a segment of the below the common iliac it's missing. So whether you can put a common iliac to femoral graft. So that is one, iliofemoral. At least it will help in a perfusion of the thigh muscles and may reduce some amount of pain while walking. They are agriculture are common day to day. Other indication probably if you are planning to do an amputation or sometime later, it may limit the level. It may help in reducing that. So it may land with the BK or what. Not now. Risk of amputation at the end of 5 or 10 years is as high as 10 to 20% in this type of patients. Okay, sir. These are a few questions from my side, sir. Anyone also want to ask?
I think there are a few other things which you can do in this patient is, in the medical treatment which is there nowadays, the newer oral anticoagulants which are there, especially the rivaroxaban which is there, is being used also for the arterial thrombosis. This was originally described for the venous thrombosis, but it is being used in the low dose for the arterial thrombosis also. So in this patient, because on the CT angio, there is hardly any distal runoff is there. So you have to probably go for the medical treatment in this patient. And the most important, the pain relief which is there. You have to provide the pain relief to the patient, whatever the way this patient has got, starting with the various types of the, what is the WHO ladder pattern which is there, starting the oral drugs and then going to the morphine, even going to the other drugs which are there, the gabapentins. All those drugs can be used, and even you may have to go for the celiac blocks which are there. So you may have to take the help of the anesthetist to do the blocks of the various types in this patient.
Yes, sir.
Sometimes the sympathectomy is, that was also, but nowadays, though it is not carried out, but sympathectomy also has some role in this patient because you don't have anything else to do for this patient. And then the stem cells which are there, okay, the stem cell which is there is also the thing which can be carried out that you can, which may provide some, not really the vascularity, but some type of the betterment may be there in the limbs in terms of the pain, and also if there is some ischemia is there may be some betterment may be there providing with the stem cells. So all those things can be carried out for this patient. On the left side, which is there, as I told you, there is one artery which is there. One can think of carrying out some type of the hybrid procedure in this patient. The hybrid procedure in the vascular surgery? What is the meaning of that?
Not properly, sir, but I heard it.
Hybrid is the combination of the two things usually. So you can combine the open surgery along with the endovascular. So like one segment may be tackled by the open surgery, another segment may be tackled by the endovascular surgery. And if you combine that, probably there may be some benefit, especially on the left side which may be there. Because all these things which are there for the treatment of this patient. Now, Rahul, if you want to do a revascularization, the open surgery, what are the various things which can be used?
If I want to do open surgery.
Yeah. You want to carry out the revascularization?
The graft.
Yeah, graft.
Graft.
Right. So what are the things which you can use? One, you said the graft. Which graft you are going to use?
Autologous graft is best. Great
what is
saphenous vein, short saphenous vein, italic, basilic vein.
Okay. So if you have to
Yes,
use the great saphenous vein, you know, if there's a infrainguinal pathology is there, it is always used. They're better to have the autogenous one. Okay. And in that, the great saphenous vein is of real boon in that. So if you have to use the great saphenous vein, how it will be used? Any idea?
Yes, sir. There is a one retrograde or something.
Basically, one is that you will do the reversed saphenous vein grafting. You have to reverse that.
Reverse.
If you do not reverse, because the walls which are there, so the blood flow will not be there. So that is why you have to reverse. So this is called a reversed autogenous vein graft.
Reverse autogenous.
Second type is the in situ vein graft, which is there.
In situ.
In situ, that you do not remove the saphenous vein from the bed, it remains there, but you do the anastomosis proximal to proximal, distal to distal, but you have to always damage the walls there.
Yes, sir.
Use the valvulotome for destroying the walls. If you do not destroy the wall, the blood will not flow in that direction.
Yes, sir.
Okay, so that is the in situ type of the venous grafting which is there. So for infrainguinal variety, it is always better to use the autogenous. But when the suprainguinal is there, like in this patient, in your patient, there is a block right at the common iliac on the right side. So if you have to use that, then in that case, you can use some type of the prosthetic graft which are there.
Yes, sir.
Which graft is there? What is the most common which is used?
PTFE and DACA.
Yes. So PTFE is the most one. And what is the PTFE? What is the
polytetrafluoroethylene?
Right. So nowadays, what is called as the EPTFE?
Extended.
Expanded one. So that graft which is used for the suprainguinal, but for the infrainguinal, you are going to use some type of the vein, autogenous vein has to be used.
Yes, sir.
Okay.
ये लोग बैठे हैं कोई इसलिए ज्यादा बातें कर रहा है
Any other questions we can?
अच्छा नगाड़े बॉस ने ज्वाइन कर रखा है
Dr. Srinivasan, can we go to the next patient?
Yes, sir. Sir, maybe we should allow Rahul. Rahul, do you have any doubts to ask, ma?
No, sir, not.
Shilpa ma'am, would you like to give your comments?
Rahul, as sir said, lumbar sympathectomy was followed previously. It was now patients don't come at that time. It is done in two indications. One is digital ischemia and cutaneous ulcer. Because lumbar sympathectomy, it reverses. In sympathetic stimulation, there is cutaneous vasoconstriction and muscular vasodilatation. In sympathectomy, the reverse happens. So you'll have a cutaneous vasodilatation. So the digital ischemia will get cured and the small ulcers will come. But patients don't come to us at that day. That is why I was not stressing about that one. But previously we were asked. Okay. Right.
Yes, sir.
Shilpa madam.
Yeah, no, you people tell me I am going to be the silent observer.
No, madam, no, madam.
The first time he presented, so please let us have your views on his presentation skills, what he can improve, what he needs to dwell upon. I think that will be a rewarding experience for him.
And he presented well, madam, but he is a bit shy and a bit shaky. That's why he should be bold. He should present more cases. And all answers he knows, but he's not able to think. And as Professor Shana mentioned in the PPT presentation, there are some mistakes which is obviously seen. That small mistakes you have to correct, Rahul. Otherwise, you presented well. Okay, you have to present more cases.
Yes, sir.
And just nothing, madam. He has done well. Actually, you said first time, and we can understand this is a. If I am not wrong, he's a just entered final year, I suppose.
Yes, and I think he was told only a day or two, back after the post emerged. So it's
That too,
difficult for him.
this looks like a COVID batch of people, we call them. 2020 joined, correct?
Yeah.
2020.
And still he has done very well.
Yes.
And he has quite answered most of the questions.
Correct.
A little more confidence, and he will fare well, very well.
One thing you should know, Rahul, irrespective of, there is some difference in the expectations from the sometimes south, sometimes from the Bombay, or sometimes from north, whatever it is. But basic fact remains is that do a complete clinical examination. That's all I would like to tell you. You understand? I have found that when Mumbai examiners, when they come to Manipal as examination, very practical, very, very practical. In other words, they may not expect you to do some postural test or something like that. On the other hand, if you look at our side here, south, a lot of importance is given also to the clinical, irrespective of whatever you get ready for the complete clinical examination. That is my only advice. That's all. Thank you, madam. He has done well.
I think, Rahul,
Thank you, sir.
you did a good job.
Thank you.
Same thing is that, what happens majority of the time that you people see first the investigation and then make the diagnosis. Now, that is not the correct way. When you are presenting the examination, you have to make your diagnosis based on the clinical history and the examination. And then later on, whatever it may come. Like in this patient, if you would not have seen the CT angio in this patient, I'm pretty sure you should have made a diagnosis of the Burgess disease in this patient rather than the patient with the atherosclerosis. Okay. So always make it a habit that you should try to make diagnosis based on the, that thing, because now there is so easily available all investigations are there. You start seeing all those things. That is okay. But still, I think, especially from the examination point of view, you must make this policy that you make your diagnosis based on the clinical history and the examination. And then whatever it may come, that will justify it.
Sir, it has become now uniform, sir. Yesterday also in the Delhi scope, I have seen telling 2 by 2 centimeter swelling has become 6 by 6, like because there is ultrasound finding is there.
Right,
so that's what is happening now, even here also in our place. But we tell that it's a very good point, sir.
Yeah, I hope he listens to you, because we keep trying to tell them this, but hopefully he'll listen to a whole group of people telling him the same thing. So thank you for allowing him to present. And Dr. Kanagavel, I shall say good night.
Good night, madam. Thank you very much. Thank you for staying with us for this class.
Thank you.
Dr. Rahul, you can stay with us for the next case discussion also. Dr. Hari is from Madurai Medical College.
Yes.
Please start your video and start your presentation, Hari.
Yes, sir.
Hari, switch on your video, ma. Yes, good to go. Start introduce your unit chief, HOD, and then start your presentation.
Yes, sir. Yes, sir. So good evening, sir. Myself, Hari Prasad, third year PG from Madurai Medical College, sir. My chief sir is K. Sarunan, sir. My HOD sir is Syed Ibrahim, sir. Today, I am going to present on varicose veins. A 45-year-old male patient, Mr. Kannan, daily laborer by occupation, native of Madurai, came with the complaints of arterial dilated veins in the left leg for the past 2 years, sir, with pain in the left leg for the past 5 months. This is the patient, sir. Clinical picture. History of presenting illness. Patient with chief complaints dilated and arterial for the past 2 years.
Hari, I think your audio is not okay, ma. Hari?
It is initially appeared on ankle region, which is just above.
Hari?
Hari, your voice is breaking. Remove the headset.
It is associated with pain, which is for past 5 months. Increase in onset, dilating type,
Dr. Hari, your audio is not okay, Kanna.
He's not listening to us. Hari, you remove your headset and speak in the directly.
Hello, sir. Hello.
Hari, your audio is not good.
In spite of checking, still these boys have, I don't know whether
Hari,
hostel has some issue.
Hari, you
Hello,
do
sir.
one thing. You switch off your video and then you can show the slides. Maybe that time it's clear. I don't know.
Remove the headset.
No, only the PowerPoint, Hari.
Yes, sir. So can you hear me, sir?
You share the. Yeah. Very
Sir,
well.
can you hear
Able to
me?
hear you, Kanna. You have to show the PPT alone.
Yes. Yes, sir. Can I proceed, sir?
Yes, please.
Yes. So a 45-year-old male patient, Mr. Kannan, daily laborer by occupation, native of Madurai, came with chief complaints of tortuous dilated veins in the left leg for the past 2 years, sir, with pain in the left leg for past 5 months. Sir. This is the patient clinical picture, sir. History of presenting illness. There is a dilated tortuous vein in the left leg for the past 2 years, which is insidious in onset. Initially appeared in ankle region, gradually progressed just above the knee, sir. And is also associated with pain over the left leg for the past 5 months, sir, which is insidious in onset, dull aching type, intermittent in nature, aggravated on prolonged standing and walking, sir. Usually it is increased towards the end of the day, which is relieved on lying down, sir. History of prolonged standing presence, sir. History of increased pigmentation over the left leg for the past 5 months present, sir. No history of night cramps, no history of prolonged immobilization, ulcer, fever, trauma, abdominal distension, loss of weight or loss of appetite, constipation, swelling of legs, itching, and history of compression stockings previously. Past history, no history of similar complaints in the past, no history of comorbidities like diabetes mellitus, hypertension, tuberculosis, asthma, epilepsy, no history of prolonged hospitalization or immobilization, no history of previous surgery, sir. Personal history, patient consumes a mixed diet, normal bowel and bladder habits, chronic smoker and alcoholic for the past 15 years. Family history, no significant family history, no history of similar complaints in his family. My history part is over, sir. So can I proceed with general examination, sir? Sir?
Please wait for faculty to ask questions, ma, in the history
Yes, sir.
part of it.
Okay.
What is the profession of this patient?
So he is a daily laborer, sir.
Okay, what type of the work is
daily laborer, sir. Daily wage.
Okay. You know, what are the various risk factors for the varicose veins? Hello, are you there? Dr. Hari?
First of all, sex, sir. Yes, sir.
Yes. What are the various risk factors for the varicose veins?
Sir, first of all, female patient are more prone for varicose veins, sir. Has increased risk for varicose vein. Then those who work in those who has worked for long-standing hours has increased risk of varicose veins, sir.
Can you enumerate few jobs which are likely to have the varicose veins?
Yes, sir. Tram drivers and daily laborers and tea stall workers and those who sell daily laborers and those who involve in strenuous activities, agricultural, those who are involved in agriculture.
You know, in the medical doctors who are responsible,
Yes.
likely to
Yes,
have
sir.
yes,
Yes, sir.
who are likely to have more of the yes problem.
Surgeon, sir.
Surgeons.
Yes.
If you have to stand for a very long time, prolonged surgeries
Yes,
will get it.
yes,
You
sir.
also have the risk factors. Okay. What are the other risk factors which are there?
Mm. Other
You know, what are primary varicose veins and what are secondary varicose veins?
primary varicose vein, we don't know any causative factors without any cause, sir. Secondary varicose vein, there is underlying cause for the varicose vein, sir.
Like, which is the commonest cause for the secondary varicose vein?
Sir, commonest, I don't know, intra-abdominal mass
Intra-abdominal mass is not
loaded.
Which intra-abdominal
Pregnancy, sir.
we can accept which intra-abdominal mass can cause the varicose vein? Normal physiology.
Pregnancy, sir.
Pregnant uterus. Yes. So that is,
Yes.
but what is the commonest cause for that? You know, pregnant uterus is okay. But what is the commonest cause for the secondary
Okay,
varicose veins? It's the DVT. No?
Okay.
Deep vein thrombosis
Okay.
is the commonest cause for the secondary varicose veins.
Okay, sir. Okay, sir.
Right. What is venous claudication? Now, we have discussed in the previous one also. What is venous claudication? At what time of the day these patients they get the pain? The patient who has got the varicose veins, at what time of the day they will get the pain in the limbs? Usually in the evening time. No?
Hari?
Hari, are you there?
I think he has poor. I think his slides are back.
Yes, sir. It is,
Hari, you try and get hold of one of your other friends' network, ma. Hari? I'll try to speak to him.
hello, sir.
Yes, Hari.
Yes, sir.
Maybe you can borrow one of your other friends' hotspot or something.
The evening time, sir. The hotspot only, sir. Hello, sir.
Go ahead, ma. Go ahead.
Yes, sir.
So I was asking when a patient of the varicose veins, they usually get the pain. What
Sir,
time?
towards the evening, sir.
Yeah,
Towards the evening, sir.
Right. Okay. You know what is venous gangrene?
Yes, yes, sir. Due to chronic venous hypertension, there will be congestion of blood, sir. Complication of it is a complication of venous hypertension, sir.
What is that condition called as? Before the patient has the venous gangrene?
So chronic venous insufficiency.
The chronic venous insufficiency usually do not get the venous gangrene. Something
Yes.
happens to the lymph which is there. Have you heard of the phlegmasia?
Yes, sir. Yes, sir. Yes, sir. Phlegmasia, alba dolens, and cerulean dolens.
Yes. So if the patient has got the severe DVT which is there,
Yes, sir.
especially the patient has the iliofemoral type of the DVT which is present, and those
Okay,
patients are likely to have the venous gangrene.
Okay. Okay, sir.
You can go on to your examination.
Patient is examined after obtaining consent in evaluate room, sir. Patient is conscious, oriented, moderately built and moderately nourished, afebrile, no pallor, no icterus, no cyanosis, no clubbing, no pedal edema, no generalized lymphedema, sir. ECOG score is 1, sir. Vitals, pulse rate is 80 per minute in the right side radial artery, sir, in sitting position, sir. It is regular, normal volume, no specific character, all peripheral pulses are felt, sir. No vessel wall thickening seen, sir. Respirate rate 14 per minute, sir. BP 110 per 80 mmHg, measured in right upper arm in sitting postures. Examination of left leg. Patient in standing position, exposing from umbilicus to toes. On inspection, attitude is normal with no deformity. There is a dilated tortuous vein seen in medial aspect of the left leg, extending from in front of malleolus towards the middle aspect of leg up to the lower 1/3 of the thigh, sir, in the middle aspect. Skin examination, there is a hyperpigmentation around ankle on the or the left leg, sir. There is no edema, no scars, no ulcer, no dry skin, no loss of hair, no brittle nails, sir. On palpation, it is not warm, not tender. There is no thickening of skin, no pedal edema, sir. No inguinal lymphadenopathy, sir. Examination, broad is Trendelenburg test 1. The vein fills rapidly from above downwards, sir. It indicates there is a saphenofemoral junction incompetence, sir. Broad is Trendelenburg 2 test 2, sir. Vein fills gradually upwards. It indicates there is also a perforator incompetence, sir. On multiple tourniquet test, there is a dilated veins appears between first and second and third tourniquet also, sir. So it indicates there is also above knee, below knee, and lower leg perforator incompetence are present, sir. Marcy's cough impulse test. I can't able to feel a cough impulse on saphenofemoral junction, sir. Teagon's test, the blowouts are seen. It indicates there is a perforator incompetence, sir. In my case, there is 3 to 4 perforator in the lower leg, sir. So modified Perthes test. The veins are shrink. Veins got shrink and not become prominent, and there is no pain on walking, sir. It indicates there is a pattern deep vein, sir. Auscultation, no bruit heard. Examination of peripheral arterial system. All peripheral pulses felt on both sides. No distal neurovascular deficit, sir. Examination of opposite side lower limb. It is normal, sir. There is no similar type of dilated veins present on the opposite side. No scars, sir. Other system examination. Per abdomen. Soft, no organomegaly, bowel stones plus, no mass palpable, no free fluids. CVS, S1, S2 here, no murmur, sir. RS, normal vesicular blood sounds here, no added sounds, sir. CNS, no focal neurological deficits, sir. Sir, summary, sir. A 45-year-old male, a daily laboratory occupation, with chief complaints of dilated tortuous vein over left lower limb since 2 years, with pain since 5 months. On examination, varicosity is present involving the left great saphenous vein. With the Trendelenburg test 1 and 2, suggestive of saphenofemoral junction and perforator incompetence, sir, with no signs of deep vein thrombosis. So, my diagnosis is primary varicose vein of the left lower limb involving great saphenous vein with saphenofemoral junction incompetence and the above knee and below knee and lower leg perforator incompetence, sir. With the CAP classification C4A, EP, A, S, and S plus P, P, R, sir, with no signs of deep vein thrombosis.
Okay, Hari, can you go to the first slide of the examination?
Yes, sir.
Why have you mentioned here the ECOG score?
So it indicates patient general condition, sir. If ECOG is very poor, primary surgery can be avoided, sir. Patient can be treatment depends on we can decide based on ECOG scores.
What is the full form of the ECOG?
So European I forget, sir.
This is the Eastern Cooperative Oncology Group. Okay.
Okay. Okay.
So this has been given by the oncology persons.
Okay.
So are you suspecting any malignancy here?
So no, sir. No, sir.
So majority of the time, telling about the ECOG or the Karnofsky scale which is there, it is for the patients who are suspected to be having a malignancy.
Okay, sir.
If the patient is, you are not suspecting anyway that the patient is having a malignancy, then usually it is not required to give this, the ECOG or the Karnofsky scale which is there. Okay.
Okay.
Go to the next slide. Go to the next slide. Okay. Did you measure in this patients or is it required to measure the ABPI in a patient having the varicose veins? You know ABPI? Hari, are you there? Hari, are you there?
Sir, I think he has some network issues, sir. I will call him and ask him to join in another network, sir.
Sir,
Give me 2 minutes, sir.
Yes, sir. Ankle brachial pressure. I am here, sir. Hello, sir.
Usually how it is measured? What is the way of measurement of the ABPI?
Hello, sir. Can you hear? Hello, sir.
Yes. Hari, can you hear me?
Yes, sir. I can hear you, sir.
Okay. So I'm asking,
So usually,
how do you measure
sir,
the
usually,
ABPI?
yes, sir. We should record the systolic blood pressure for all 4 limbs, sir. In lower limb, we will take either dorsalis pedis or posterior tibial, sir.
And how do you
We should
record
take the
what is the good way of recording the systolic pressure?
with the Doppler, sir. Handheld Doppler, we can see it accurately, sir.
Ideally, you should have a handheld Doppler for that, you know?
Yes.
And you should
Yes,
measure the systolic pressure in that, and then you should take out the mean of that and tell about the ABPI.
Yes, sir.
So what is the normal ABPI?
Yes, sir. Sir, 0.9 to 1.1, sir.
Okay. If it is 1.3 is there, 1.4 is there, is it a good one or it's a bad one?
So it is mostly due to calcification or calcification, sir.
So that is
No,
also
1.4.
not good, you know? Okay, so
Yes,
that
sir.
doesn't
Yes, sir.
mean the patient limb has got very good circulation. If it is 1.3 or more than
Yes,
that,
sir.
that also tells you about
Yes,
the disease limb which is there. Okay.
Yes, sir.
What is the significance of ABPI in a patient who has got the varicose veins? Why you want to measure that?
So if a patient has reduced lower ABPA, we are using compression stockings for varicose veins, sir.
Right.
We should give lesser compression if it is associated with arterial problems, reduced ABPA, sir.
So that's true that you have to check if you are giving the patient the compression treatment, you should use the lower pressure for that, you know, if the ABPI is
Yes,
low.
sir.
And the second is that many of these patients, we think that it's the venous ulcer. Almost about 30% of the patients may have a mixed component may be there. There is a venous component, but the arterial component is there. So that is why the ABPI should be carried out in a patient with a suspected varicose veins or the venous ulcer which is there.
Okay.
What is the false thing which is there about the modified Perthes test? You know, you said it is for the deep veins, is it? But when this test will not be applicable?
Modified Perthes. If it is
yes.
If there is any deep vein thrombosis.
No, that is the positive finding. But when this test is not good, like in your patient, what is the thing which is there where I will say that probably modified Perthes is not good? Your patient also has suspected perforator incompetence.
Yes, sir. Yes, sir.
So the patient has got the perforator incompetence is there. Then in that case, the modified perthes which is there will not give you an appropriate thing that this patient is having a deep vein thrombosis. So in that patient, if somebody has got the perforator incompetence is there, then you should go for the classical perthes test. You know what is the classical perthes test which is there?
Yes, sir. We should tie the rubber bandage from the ankle to till below the GSV, sir. Then ask the patient to walk, sir.
So if the patient has a perforator incompetence, it will be better to go for the classical perthes test. All right.
Okay.
Now in the Fegan's test, you said you feel. Can you go to the Fegan's test? Where you are showing the Fegan test?
Yes.
Show that. You said defect is seen. What is that defect is seen?
So there is a blowout, sir.
Okay, you can see the
blowout that I can.
But this Fegan test is mainly the palpation one. So what do you palpate?
Okay.
What do you palpate?
The defect in the fascia through which there will be a defect in the fascia through which the perforator arises.
So which is that fascia? Which fascia is that?
Deep fascia, sir.
Deep fascia.
Deep fascia.
Right.
Yes.
So you know how to do the Fegan test? How do you do the Fegan test?
Yes, sir. I asked the patient to stand, sir. There will be a dilated veins on inspection, sir.
Yes.
Then I asked the patient to make supine. Sir, can you hear me, sir?
Yeah, I can. But
yes, sir.
You cannot make the patient supine after that. You will do something else. When the patient is standing, you have to do something before you can go for this Fegan test. You have to mark the vein. No?
Yes, sir.
Yeah, the mapping has to be done. So when the patient is standing, you see that where is that particular vein which is there. So you have to map that. You have to put the mark there. And then you make the patient lie down and then you feel for the defect which is there. When do you say it is a defect which is a, that perforator which is there, it is incompetent? How much defect should be there to say it is incompetent?
I don't know, sir.
So the defect has to be at least 3.5 millimeters. Okay, 3.5 millimeter, and that is the thing which you see on the ultrasound or the duplex scan when you are carrying out. There is a reversal of the flow is there, usually more than 500 milliseconds, and also there is a defect of more than 3.5 millimeters diameter. Then you say that particular perforator which is there is a incompetent perforator.
Yes, sir.
Okay. Right. Now, which SEEP classification you applied in this patient?
Fine.
Can you go to the last slide? SEEP, where you are showing SEEP? Show the SEEP, last slide.
Okay.
No, it is not come. Your last slide of the summary.
Yes, I am showing, sir. Can you see this?
Okay, can you tell that which SEEP you have applied? Which modification? Any idea that SEEP has been modified now? Huh? You know that? Hari, can you hear that?
I think his connectivity is again bad, sir.
The connectivity is the problem. He's showing the
You
slides.
can hear that.
Okay.
Yes.
So, you know, in 2020, the SEEP has been modified.
Yes, sir.
So what is the modification which is there of the SEEP classification?
Sir, addition of 4C is there, sir. For
so what is 4C? What is 4C?
4C.
And where it was in the classical SEEP and where it has come now?
In 4B, it is lipodermatosclerosis, sir. In now it is 4C.
No, that is not lipodermatosclerosis. It is a corona
Phlebitis.
Flabectic. Nice.
Yes,
Very
sir.
difficult to
Phlebitis.
speak that. Okay, so that
Okay.
was originally in which C it was?
Okay, sir.
Originally, this corona was in the C1.
Okay, sir.
Okay, means there were only the reticular veins which were there around the ankle.
Okay.
But it was observed that the patients who have got this corona which is there, they are very likely to have the venous ulcer. And that is why that has been shifted now to the C4C now.
Okay, sir.
Okay. What are the other differences which has come? What are the differences? Now the recurrent has been added. So now in the C2, the C2R is there.
Okay.
Similarly, in the C6R is there, which suggests that there, after your treatment, there is a recurrence is there.
Okay, sir.
Then there is a change in the anatomical one. What are the changes in the anatomical which has happened? Okay, in the last C classification, you always say that, okay, this particular segment is there, but now you have to name the particular vessel which is there.
Okay, sir.
So if it is GSV, great saphenous vein, A is above the thigh, B is below the thigh. So now the full name has come in that. So these are the few and also there is one in the E also, that whether it is a extra venous component or the intravenous component is there. So these are the few modifications which has been made in the C classification.
Okay, sir.
You know what is ambulatory venous pressure?
Yes, sir.
What is that?
Sir, actually, for measuring ambulatory venous pressure, we should cannulate dorsal vein, sir, and connect it to your transducer, sir.
No. What is what is the ambulatory venous pressure?
It is a pressure in the venous system.
While you are ambulatory, when you are moving, then if you measure the pressure, that is the ambulatory venous pressure. What is the normal venous pressure in the standing position at the level of the ankle in a normal person?
20 mmHg, around 20 to 30 mmHg.
Normal venous pressure at the level of the ankle in the standing posture.
So it should not be more than 80 mm, sir, between 20 to 80.
It's around 80 to 90 millimeter mercury.
Okay.
And what is the normal ambulatory pressure? Normal ambulatory pressure is around 20 to 30.
Okay, sir.
So when you start walking, that venous calf form start working, the pressure goes down.
Okay.
And this is the ambulatory venous pressure which is responsible for the venous insufficiency. If the ambulatory venous pressure doesn't fall, like it doesn't fall from the 80 to 20 or 30, it remains 70 or 80, then these are the patient who has got the venous ulcer.
Okay.
So normally the ambulatory venous pressure should fall if you measure that. But in these patients, if the venous ulcers are there, you will find that though the normal resting pressure will be the same, 80 to 90, but the ambulatory pressure will be high in the patients with the venous ulcers.
Okay.
So how you are going to work up on this patient, investigate this patient?
So I will do routine investigations like CBC, BTCT blood grouping, sir, and RBS, urea creatinine, blood sugar, sir, with ECG X-ray, sir. Specific investigations, I will do duplex studies, sir.
What do you
And
mean duplex one? What is the meaning of duplex study?
So it is a B mode ultrasound with Doppler, sir, combined with Doppler, sir.
So what are the things you see on the B mode and what are the things you see on the duplex? Means the Doppler.
So in Doppler, I will see the reflex, sir, whether patent or not, sir, incompetence presence or not.
When you
in B mode,
when you say it is a
when there is a signal of whoosh more than 0.5 seconds, sir, there will be it indicates it is a reflex.
So how do you demonstrate that? In which position you carry out the Doppler? In which position you should carry out the Doppler study?
So with knee flexed, and hip extended, sir, externally rotated.
You mean the supine position?
Yes, sir.
It is never done in the supine position.
Okay.
It is always done in the standing position. And the patient should bear the weight on the opposite side.
Okay.
Okay, so if you are examining the right lower limb, the patient will bear the weight on the left lower limb.
Okay.
And you slightly flex over the knee and the hip joint. And then you look for that. Okay. So by the ultrasound, you are going to see the anatomical things which are there.
Okay.
By the Doppler, you are going to see that physiological thing which is there and how much is the reversal of the flow is there.
Okay.
So when you say that this, if you have to measure the saphenous vein, at what level you usually measure to say it is the varicose veins?
Sir, I can't understand your question, sir.
No, your ultrasonologist will tell you that, sir, this is the measurement of the great saphenous vein. This is the diameter of the great saphenous vein. So at what level usually he measures that?
At the saphenous opening.
No, it is almost at the mid-thigh.
Okay, sir.
The mid-thigh level, usually he will give you an idea, sir, this diameter of this particular vein is 5 millimeters or 6 millimeters or 8 millimeters. When you say it is a varicose vein, how much diameter?
When it is more than 4 millimeters.
Okay. Some say 3, some say 4 millimeter. Yeah. Okay. Yeah.
Oh, okay.
Now, if you have to see one thing on the Doppler in a patient with a suspected varicose veins, what is that most important thing?
So whether deep venous system is involved.
Yes. So that is the most important thing you want to see, check, because what is the significance of that?
So we should not operate for this patient. So we should not intervene for the patient. Sir.
And there should be no active intervention.
Yes.
Okay. So is it always a contraindication that you should not, a patient who had the DVT, that you should not tackle the superficial veins?
So we can try for alternative methods.
Like, which are the alternative methods?
Like sclerotherapies.
No, but that will be the same thing, isn't it? Yes. If the patient has got the DVT is there, usually that is, from at your level, you can say that probably you will not do any active intervention for that. But it has been seen that if there's just one attack of the DVT is there and you do the ultrasound later on and you find that the deep veins are cleared and the patient has got varicose veins, you can go for the active intervention of that also. Okay. But at your level, it is okay that once the patient has the DVT, you should say that you are not going to do any active intervention for that. Now tell what are the various active interventions in the varicose veins?
So first we can go for surgery, sir. Trendelenburg procedure with stripping of with perforated ligation, sir.
Okay. So what is the Trendelenburg operation?
So it is a juxtafemoral flush ligation of greater saphenous vein, sir.
And
Stripping of the vein, sir. Till below the knee, sir.
Stripping is not a part of the Trendelenburg operation.
Yes, sir. Just.
But there is something else which is a part of the Trendelenburg operation.
The ligation of the tributaries.
Yeah, ligation of the tributaries which are there. How many tributaries are there usually?
So 3, sir.
Okay, what are those?
Superficial epigastric,
yes.
Superficial external potental, and superficial external iliac.
Superficial circumflex iliac.
Circumflex iliac.
Right. Okay, so these are the usual 3 veins. So that is also ligated. That is the part of the stripping is an extra part. Okay.
Yes.
Okay, it is not a part of the Trendelenburg operation. What are the other surgical interventions which can do? Apart
we can try for, sir.
Yeah, what one you told the Trendelenburg operation. What are the other surgical options?
Yes, sir. We can try for subfacial ligation of perforators, sir. Then radio frequency ablation.
No, surgical. And, first tell about the surgical.
Yes, sir.
Surgical is that you can go for the mini phlebotomies.
Yes, sir.
Okay, you can go for the subfacial ligation of the perforators.
Yes, sir.
And any technique where you spare the main truncal vein, the great saphenous vein, but you are taking the other things, other leakage points. That is called the saphenous sparing surgeries. Any idea about that?
No, sir. Where we will not remove GSV, sir, without addressing incompetence.
Like the Chivas technique, which is there, CHIVA.
Okay.
So that's the French technique where you are not doing any damage to the main vein which is there, but you are looking only at the leaking points from where, and you are taking control of that. But it is usually not done. So main is the Trendelenburg operation, the stripping which is there, and the mini phlebotomies. So these are the things. Now tell what are the various minimal invasive techniques which are there.
Radio frequency ablation, sir.
Radio frequency ablation, yes.
Yes, sir.
Any other?
Endovenous laser ablation, sir.
Yes. So they are called as endothermal ablation techniques.
Okay, sir.
Endothermal ablation technique, of which is one the RFA, another laser. Okay. Any other endothermal techniques,
Trivex method.
You can use the steam also,
Okay.
In place of the RFA and the laser, you can use the steam also, and also you can use the microwave also.
Okay.
So these are the thermal techniques which are there. Then any non-thermal techniques? Any non-thermal techniques for tackling the varicose veins?
The Trivex method, sir.
Okay.
Hello, sir.
It is either, have you heard the name MOCA? MOCA?
Yes, sir.
It is mechanico-chemical ablation.
Okay.
Okay. Or you can use the glue. Cyanoacrylate glue can be used.
Okay, sir.
Or you can use the sclerotherapy.
Yes, sir.
Have you ever seen a sclerotherapy for the varicose veins?
Yes, sir. I have seen, sir.
Okay. Which type of the foam, which type of the sclerosant was used?
The sodium tetradecyl sulfate, sir. I used.
Okay. So how did you use that? You know that how did you use?
Yes, sir. I will take 1 ml of sodium tetradecyl sulfate with 4 ml of air, sir. Okay. I will mix it with in the syringe, sir.
So what is this technique called as?
Tessary, sir. Tessary technique.
Okay, Tessary technique, no?
Yes, sir.
And you make the foam of that, foam sclerotherapy. Yes, so this is not the liquid sclerotherapy, but this is the foam sclerotherapy.
Okay.
So what are the uses of the foam sclerotherapy? What are the various places where you can use it?
Sir, we can use it for thread veins and reticular veins, sir, and few perforators also.
So you can also do, apart from the thread vein and the reticular veins, you can also use the truncal vein also. Also
Okay.
the non-truncal veins which are there, or the recurrent veins which are there.
Okay.
Sclerotherapy has been used for almost all the type of the veins which are there, and especially the patient of the recurrent vein is there after some treatment.
Okay.
You know what is E-hit? Have you heard the E-hit? E-H-I-T? That is the complication of all these techniques which are there.
No, sir, I don't know.
E-hit is endovenous heat-induced thrombosis.
Okay.
Okay. So if you are using like the RFA or you are using the laser, what precaution is done to avoid this technique? What is the technique?
Yes, sir, we will inject lignocaine.
No. You stay at least 2 centimeters from the saphenofemoral junction.
Okay.
Okay. So your tip of the laser or tip of the RFA which is there, it has to be at least 2 centimeters proximal to the saphenofemoral junction.
Okay.
And similarly, if you are using a cyanoacrylate glue, then how much it should be away from the saphenofemoral junction? The tip should be at least 5 centimeters away.
Okay.
Okay, so that is like here it is called a E-hit, and there it is called a E-git, G-I-T, glue.
Okay.
Okay, endovenous glue-induced thrombosis.
Okay.
Because once this glue goes into the deep veins, then there is no other option than either the patient will definitely have the deep vein thrombosis or you have to remove it by the surgical method.
Okay.
So that is why you keep around 5 centimeter proximal, while in the RFA and laser you keep around 2 centimeter proximal to that.
Okay.
Which laser is used for this? Which type of the laser is used?
Laser.
Okay, there's a diode laser which is there.
Okay.
Okay, diode laser. And you know what is the frequency of this diode laser which is used nowadays? Okay, when it started, it was 980.
Okay.
Okay. Then majority of the people now use the 1470.
Okay.
And the most latest is the 1920.
Okay.
Okay. The advantage of the 1920 is there, that there is less chance of having the bruising which is there. So less pain is there when you're using the 1920.
Okay.
Then you know any non-invasive technique which is coming for the varicose veins? This is called a HIFU.
Okay.
HIFU. No? This is high frequency ultrasound.
Okay.
So instead of making any incision which is there, you can, with the help of the ultrasound, you can block the veins.
Okay.
Though it is not available very regularly. Okay, at very few centers it is there, but this is a non-invasive technique which is there for the treatment of the varicose veins.
Okay.
What is the role of compression stocking in the varicose veins?
It prevents complications like ulcer, complication of varicose veins, sir.
This is one of for the treatment of varicose veins, compression therapy is one of the treatments for that. The medical treatment.
Yes, sir.
Okay. And you know, what is the pressure which you have to use for that?
Around 30 to 40 mmHg, sir.
30 to 40 mm is for if the patient is having a venous ulcer. Then you use a 30 to 40. But if it is just for like C2 disease, which is there, which is up to the varicose veins only, then in those cases, it's around 20 mm of mercury.
Okay.
What is the treatment of the venous ulcer if it is there? How can you treat the venous ulcer?
So by that regimen, sir, Biscard regimen is there, sir. I will frequently I will ask make the patient to elevate the limb, sir. And then I will do the daily dressing, sir. 4-layer dressing can be done, sir.
Biscard is usually not done nowadays. So your answer should be that you will go for the 4-layer compression bandage. Okay, so that should be the answer, that you will go for the 4-layer compression bandage.
Okay.
Right. That is the main treatment for that.
Okay.
Plus you have to also tackle the varicose veins also.
Okay.
So either you have to go for the RFA, or you have to go for the laser, or you have to go for the sclerotherapy to tackle the veins. Because if you do not tackle the veins, there is very high chance of having the recurrence of the disease is there.
Okay.
I think that's it. Anybody else wants to ask any question?
Hari, just a few questions to complete problem. Just name some complications and how do you treat them?
Yes. First, hemorrhage, sir.
Yes.
I will treat it by leg elevation and compression stocking, sir.
What do you think the cause of the varicose vein bleeding?
Due to trauma, sir.
So anything else without a trauma also? Yes.
Yes, sir.
Without a trauma, eczema, dermatitis, patient will start itching. Even a spontaneous, when the venous hypertension increases, no, you will get bleeding. Yes.
Okay.
Then what else? That becomes one of the important indications in addition to symptomatic. Yes. Next.
Okay.
What else?
Sir, pigmentation, sir. Phlebitis pigmentation, sir. Then eczema, sir.
Don't mix up. You mean to say thrombophlebitis?
Yes, sir.
Right? So in the inspection wise, when you are describing an ulcer, you have to describe it, dilated veins, tortuous, blowouts, etc. In addition, you also should mention any redness. Okay. Because infection means probably one should not do immediately surgery. Similar on palpation, any cord-like feeling, when you feel the varicose veins. Okay. Yes.
Yes.
What is lipodermatosclerosis? How do you treat that? Lipodermatosclerosis. Yes. Hello. Hello.
Hello.
Hey.
Sir. Excuse me, sir.
You know what is lipodermatosclerosis?
So it is thickening along with induration with in the lower involving lower 1/3 of the leg, sir, due to fibrin deposition, sir.
Yes. So that is also becomes a nice treatment for compression stockings. And of course, once the edema and the swelling will come down, absolute rest, and with some compression, with the exercises, whatever we have mentioned earlier, some amount of can reduce and followed by surgery. Okay. Yes.
Yes, sir.
Then what else is there? A few other complications quickly.
Sir. Yes, sir. Venous ulcer formation, sir.
Venous ulcer is a superficial or deep ulcers?
It is superficial, sir. It don't involve deep faces.
Usually,
don't penetrate deep faces.
Usually, superficial ulcer present in the greater area, right? Yes. So you mentioned marginalis. What is that marginalis ulcer?
So it is a carcinoma arising from a chronic ulcer, sir.
What is the
Mostly squamous cell carcinoma, sir.
How does it differ from the regular squamous cell carcinoma? Any points are there which because it arises from the scar tissue, any advantages for the patient as far as the spread or prognosis is concerned? Hari?
Sir, yes, sir, I can hear. Sir?
Marginal ulcer, is it
Yes, sir.
how it is different from squamous cell carcinoma? Is it better or worse compared to
It's,
yes?
it's better, sir.
Reasons?
It's better, sir. Reason?
Yeah, because it's well differentiated and scar tissue, so spread is less, pain less because the nerves are and lymphatics also are not involved unless it goes to the normal skin. Okay. Yes.
Okay.
So I think few other complications are there, but anyway, time is also gone. Anyone else, sir? Please want to take ask. Anyone else wants to ask questions? Srinivasan sir, you are there. Okay, Kanakwel, can we usually now stop?
Sir, any other faculty would like to give the comments, or can we call it a close, sir?
Can I ask one question?
Sir, please, yes.
See, there is a complication
called. Do you have any doubts, ma'am?
Yes, sir.
Hari, am I audible?
Yes, sir. Yes, sir. I can hear.
And there is a complication called equinus deformity. Am I right?
Yes, sir. Yes, sir. There is
equinus deformity in varicose vein. Am I right?
Yes, sir. Yes, sir.
What is the pathophysiology? How a big equinus deformity occurs in a patient?
Yes, sir. Sir,
what is equinus?
Foot is plantar flexed, sir. Patient can't able to dorsiflex the patient, sir. Foot is can't dorsiflex, sir. Patient keeps on plantar flexed, sir.
See why?
Sir, in varicose vein, due to pain, patient to avoid pain, patient keeps on walking in tip of the toes, sir. So yes. that leads to contraction of the joints, sir.
So why it is called as equinus? That is my question. Why it is called as equinus deformity? What is equinus?
Like horse foot.
Yes.
Horse foot will be like this, sir. Heel will not be placed on the.
The horses don't have heel at all.
Yes, sir.
Yes. So that is why we call it a equinus deformity. When the patient goes on working for years together with the forefoot,
yes, sir.
There may be shortening of the tendons. Hence it is called as equinus deformity. That's all from my side, sir.
Thank you.
Faculty, any other contributions? Thank you, Hari. Thank you all the faculty. With the permission of the faculty, we call this session a close. Next week will be a session on thyroid. So there will be one benign and one malignancy of the thyroid will be presented next week. So with the permission of the faculty, we call this session a close. Kanna sir, Shanai sir, Karnakaran sir, Rawat sir, all the other faculty, good night. And students, thank you very much for joining this evening. Bye-bye.